Good afternoon to all. Thank you, organizers, for this wonderful opportunity. So the task at hand for me is to decide whether Osimertinib or Decotinib is a better drug for our frontline management of advanced non-small cell lung cancers with EGFR mutation. So at the outset, the disclosure is that there is no a single randomized clinical trial that has clearly tried to answer this question by head-to-head comparison of these two drugs. So most of the inferences that we are going to draw are from the individual clinical trials, and we'll try to limit some of the cross-trial comparison because they are not very scientific. So let's look at some of the updates from the pivotal clinical trials and what's the update from the FLORA trial. So FLORA trial, as we remember, it's a double-blind randomized phase 3 trial that tested the utility of Osimertinib versus the first generation TKI, which is Gefnib and Erlotinib. The primary endpoint of PFS was published way back in 2017, and it had shown clearly improvement in the PFS with respect to Osimertinib. It was nearly about 18 months versus 11 months. And again, what we have understand that there was initial early indicators for improvement in the overall survival as well in 2017. But the data was immature. It was only 25% maturity at that point in time. Now in December 2019, we have the update and publication led by Dr. Ramalingam. And we can see a clear improvement in the overall survival. The median overall survival was nearly 39 months versus what we can see 32 months for the comparator arm. The hazard ratio was 0.80, inferring a 20% risk reduction with the utility of Osimertinib in the frontline setting. The overall duration of utility of the drug was about the Osimertinib versus 12 months for the comparator arm. Despite higher utility, the grade 3 toxicities were less with Osimertinib at around 42% compared to 47% for the comparator arm. And the primary stratification factors for this clinical trial were the race, Asian versus non-Asian, and type of mutation, which is EGFR exon 19 deletion, or the substitution in the L858R in the exon 21. And if you look at most of the subgroups in the forest plot, and most of the subgroups have benefited with variable degree of magnitude, but the largest numerical between group differences in the hazard ratio for overall survival was observed for the Asian and non-Asian population. So if you look at the Asian population, if you look at the non-Asian population, the hazard ratio was 0.54, but for the Asian population, it is at the unity. Again, if you look at the exon 19 deletion, 0.63. Again, for the L858, it is around 1.0. And the explanation from the discussion from the publishers is that this is a secondary endpoint and the numbers are not suitable for making a direct comparison, but I would disagree. This is a primary stratification factors and there is some weightage to differences of hazard ratios for the individual subgroups. So it appears that the Osimertinib benefited non-Asians more. It also benefited the exon 19 deletion more than the substitution in the exon 21. Further updates from the FLORA trial. This is the patient-reported outcomes of the FLORA trial led by the lead author, Professor Natasha. We can see the odds of improvement and time to deterioration were similar between the two treatments. However, the cognitive functioning remained stable for the Osimertinib, but it significantly deteriorated for the Erlotinib and Gefnib, majorly because of appearance of brain metastasis. Again, there was improvements with Osimertinib for emotional functioning as well as for the social functioning. And also there is a statistical significant difference favoring Osimertinib for chest pain, but this was not clinically relevant. Coming to the CNS activity, this was a pre-planned exploratory analysis of CNS efficacy of Osimertinib from the FLORA trial. Even before the FLORA trial, we have the phase 3 AURA-3 study, which was second line utility of Osimertinib in those patients with having T790M. Again, in that trial, we can see a CNS overall response rate of nearly 70%, median PFS, CNS PFS of nearly 1 year with Osimertinib compared to 6 months for the comparator platinum combination chemotherapy. Again, FLORA trial had nearly 21% of the entirety of 556 patients. There are 128 patients with CNS metastasis. However, these CNS metastasis were stable, asymptomatic, or if they are symptomatic, they have completed definitive treatment for those symptoms. So in this FLORA trial, we can see a hazard ratio of 0.47 for the patients with CNS metastasis, 0.46 for those without CNS metastasis. So Osimertinib benefited irrespective of whether the patient has baseline CNS metastasis or no metastasis. Again, CNS progression-free survival, the hazards of 0.48 favored the utility of Osimertinib. In total, the CNS disease control rate was nearly 95% with the Osimertinib. So moving ahead with Osimertinib, there is opportunities for combination with chemotherapy. This is the FLORA-2 clinical trial. Again, the early trial data was published recently, and we can see a significantly longer PFS with Osimertinib combination with chemotherapy. Hazard ratio was 0.62, and 2-year PFS was nearly 60% versus 40% in favor of Osimertinib in combination with chemotherapy. Again, there is further improvement in the CNS overall response rate, nearly 73% with combination and about 69% for the monotherapy. There are few trials, phase 2 trials, which are in, again, recruitment. Ostara clinical trial, that is testing the combination of Osimertinib plus Amivantamab. The results are yet to be awaited. So let's look at the update from the Archer 1050. So there are some critical differences between the Archer trial as well as from the FLORA trial. Archer trial significantly included patients from the Asia and Southeast Asia. It included stratification factors of Chinese versus non-mainland Chinese. Again, the PFS was the primary endpoint. It did not include patients with the active or asymptomatic brain metastasis. The initial PFS was significantly better. Then we have an updated overall survival, which was done at a median follow-up of nearly 48 months. And again, significantly improved with Decotinib versus the Gefitinib. The hazard ratio was 0.74. And the median overall survival numbers were 34 months versus 27 months. Again, a significant majority of the patients had grade 3 and grade 4 toxicities, resulting in discontinuations and also dose reductions. Again, there is a secondary analysis which was done, and it showed that the OS and PFS for those patients with dose reductions did not actually differ compared to that of the overall population. The most common grade 3 adverse effects were rash, diarrhea, and pyrorhgia. Utility of Decotinib in the brain metastasis. Unfortunately, the Archer 1050 doesn't answer that question because there are no patients with brain metastasis in that trial, but we have a phase 2 trial, a small phase 2 trial, which included about 30 odd patients, and we can see a confirmed overall response rates in the CNS of nearly 95%. Again, 1 year cumulative disease-free, intracranial disease-free progression was around 20%. So there is appearing to be some amount of activity for the Osimertinib and as well as Decotinib in the patient with CNS metastasis. So let's briefly look at some cross-trial comparisons. If you look at the, if you concentrate on the grade 3 and grade 4 toxicities, if you look at grade 3 and grade 4 toxicities, it was 42% for the Osimertinib. It is around 77% for the Decotinib. If you look at serious adverse effects which are treatment related, nearly about 30%. And if you look at interruptions, it is 43% for the Osimertinib, but this data was not forthcoming for the Decotinib. And look at the dose reductions. Only 5% of the patients had a dose reduction for the Osimertinib, but nearly 2/3 of the patients had dose reduction for the Decotinib. However, discontinuation was 15% for Osimertinib and only 10% for the Decotinib. If you look at the hazards for the Osimertinib individual patient population, in deletion 19, there is appeared to be a better benefit with Osimertinib. In L858R, it is with Decotinib. In Asian population, it is with Decotinib. In non-Asian population, it is with the Osimertinib. I would not try to draw conclusive remarks because this was, again, a non-scientific cross-trial comparison, but the early signals and early impressions could be drawn from this. So this is a very busy slide. I try to walk through you through it. And if you look at the absolute benefit with the Osimertinib and Decotinib, both of them are showing a nearly 7 months delta with respect to the comparator arm of the Gefitinib versus Erlotinib. Again, hazard ratios are pretty much similar. It was 0.80 and 0.75 for the Decotinib. See, Osimertinib in trial design in a randomized phase 3 trial had shown a better CNS efficacy. We have to look at phase 2 trials for Decotinib. Again, if you look at the discontinuation, serious adverse effects, it was around 30%. Discontinuation rates were around 5%. For the dose reductions were around 5% for the Osimertinib, but it is nearly about 2/3 in the Decotinib. However, the overall survival benefit of Decotinib treatments in patients with dose reductions were comparable to that of the patients with overall population as well as those without dose reductions. So in my personal opinion, if you assume Indians as Asians or non-Asians, you will have to make a difference there. I personally believe that we are not Asians, and probably Osimertinib will give a better benefit for our patients. And in those patients with L858R mutation, probably we can go for a combination of Osimertinib plus chemotherapy and have a similar outcomes for those patients. Decotinib remains to be a drug that has its own challenges of toxicities, but with active dose reductions, probably we can also find similar benefit with the Decotinib also. And with that, I would like to conclude my brief discussion. Thank you very much.